Good afternoon. Welcome to the Heart Cafe on shining the light on effective strategies to manage and prevent hypertension. I'm Tom Gaziano, a professor at Harvard Medical School and scientific chair of the World Heart Federation. We bring this Heart Cafe to you. Is that better? Bring this Heart Cafe today to discuss hypertension. We are so lucky that we have four of the world's experts on the management and understanding of hypertension globally. Professor Altashuta originally from South Africa, but now residing with the George Institute in Australia. Vilma Irazola, director of the Institute of Clinical Effectiveness and Health Policy from Buenos Aires, Argentina, and a long and dear friend, working well. Pedro Ordonez, who is the technical advisor to the for cardiovascular disease of the Pan American Health Organization, and Neil Poulter from Imperial College London, who is a world famous trialist in many areas of not just hypertension and lipid management, but has really moved forward the idea of screening in shedding the light on our need for improvement in hypertension care. So let me set the stage. Hypertension affects about 1 in 7 people in the world, or about 1 in 4 adults, responsible for half of all vascular death, stroke, and ischemic heart disease. Yet, globally, only about 20% at best of the population has the condition controlled. Our best countries are in the 50 to 60%. If we were taking tests in school, those would be failing grades. And so we've struggled. And so here we're trying to understand what are some of the ways that we can potentially improve those numbers to continue to make some of the advances that we have had even better. So let me start, Alta, with the question for you. We see that there's a lot of disparities between high and low income countries. We also see that within a country, we may see significant disparities in care and treatment and management of hypertension. Can you shed some light on why that is and what we think we can do about that?
Yes, thank you, Tom. That's right. Of the about 1.4 million people with hypertension, more than 1 billion reside in low and middle income countries. So it's really important to actually target those areas where we can make the biggest difference and impact. And there has been, it's a major challenge to actually improve how blood pressure is detected and then treated and controlled. But we do have some real success stories that we can and try to scale and implement widely. And I think some of those key aspects that we need to focus on is simplified treatment protocols, often just a one-pager with very clear step-by-step strategy on how to intensify care, how to measure blood pressure correctly, that's clearly communicated and that can be understood not only by clinicians, but also community healthcare workers and nurse practitioners. There's also a lot of emphasis and successes from team-based care. My colleagues here sitting together with us in the panel can probably share their stories on how that can impact improvement in blood pressure control, not only in low and middle income countries, but also in high income countries. There's a lot of potential to implement that much better.
Well, that's a nice segue for Pedro. Pedro, she mentioned simple strategies for managing hypertension. You've been involved with the HEARTS program, particularly in the Americas. Can you tell us about how maybe it wasn't so simple to get a simple algorithm together and to put it in place, and share with us some of those challenges and successes?
Thank you, Tom. I think this, Heart in America is a game changer in many ways, because it's a new approach in management of hypertension, moving from the very specialized type of care, from the specialist type of care and cardiology type of care to the primary health care. And this is important addition and important difference when we talk about the hypertension control. In the America, 33 countries are already committed with implementation of the heart. And the protocol that you mentioned, Alta, it has been implemented in 27 countries. Simple protocol, straightforward, with a specific dose, with a specific dose, a specific step for everything that you can do at the primary health facility. So they are very happy. They are very well acceptable for the primary healthcare team. and accepted for the population, accepted for patient. So a lot of challenges, but I think that 33 countries, 27 countries implemented the clinical standardized clinical power, more than 6,000 facility, primary health facility implementing the model. We have 4.5 million person in treatment, and the control of hypertension is over 60%. So it's a really it's important process. Another important thing is for the first time uh, for the first time uh, that we have something to offer concretely to the primary healthcare physician. Many times we have a very beautiful speech talking about how important is the hypertension, how important is the management of the cardiovascular disease, but you need to something that is that happen in a community, something that facilitates the work that they are doing. So this is an important addition. Thank you very much for the opportunity, Tom.
There's just a quick follow-up. For people who aren't familiar with the hearts, can you explain a little bit more about the actual package? And in the hearts, it suggests that it's about the whole cardiovascular system. And I know there's parts about treating other risk factors. Why has it been the major focus, particularly for you in hypertension?
This is important. I think it's important and relevant. The global heart is the WHO initiative to improve the cardiovascular health. However, the technical package, heart technical package, is focused on hypertension. Main entry and the treatment of hypertension because it's a priority, no question about that. However, in heart in the American, because the country demand this kind of action, in addition to hypertension, we manage the CVD, primary and secondary prevention using the same opportunity. And now we are working in the Heart 2.0 to include all the multimorbidity because it's a challenge, and we need to use the opportunity, the contact that we have with the patient at the community level to simplify the treatment, but at the same time to tackle many other kind of conditions. So this is one of the additions. That's what I think the clinical pathway, the name is a heart clinical pathway, is very popular in the region of the American, and the number of countries implementing, the number of facilities implemented, including diabetes, CKD, previous cardiovascular diseases, and high risk of cardiovascular.
Vilma, he's in Washington, Apajo. You're in the field, in the community, in Buenos Aires and throughout the country. Explain to us, and he's also, and Pedro share with us, the idea of what we're delivering to providers to deliver in the community. Tell us what that means to actually have something like this to be developed in the community, and what are ways that we can get the community involved in all aspects, not just the physician, but other people, and what have been some of the challenges and successes in this type of care?
Thank you. Thank you, Tom. And yes, I think that the involvement of the community is key to advance in the control of hypertension. And the role of community health workers, community workers, they can have different names according to the country. For example, ASHAs in India, I remember. These are people who belong to the healthcare system but come from the community, speak the same language of the community, and they can reach more easily the community. So involving them is key to be successful in this process of involving key actors that have a role in controlling hypertension at the primary care level. And this linking between the community and the healthcare system, community health workers are the best option in our countries, not only in Latin America, but in other parts of the world as well.
Neil. So Neil, we've talked about how once we have those patients, how we care for them, a good algorithm, a good plan integrated across the country, engaging the community. But how do we find them? I know you've been very interested in screening in different ways, and particularly opportunistic screening. Share your thoughts about screening at different approaches and what are the advantages and how we can implement that best.
Thanks, Tom. Well, about almost 10 years ago, the pure data showed that less than half of people with hypertension were aware of it. So it's great having the right treatment, but you can't treat what hasn't been diagnosed. and you can't diagnose hypertension unless you measure it. And that's it seemed to us at the time, through the International Society of Hypertension, that at a global level, working out the best fourth line agent was going to affect 0.1% of people with hypertension. It was irrelevant. The key to opening up, improving control of hypertension around the world was to raise awareness. In other words, increase screening. And the WHO in their brilliant book of last year and the recent European guidelines have stressed that opportunistic screening is something we've got to put into place. So that in 2017, we set up May Measurement Month. World Hypertension Day is May 17th. But something that kills 11.3 million people per year, more than anything else in the world, deserves more than one day. So we went for May Measurement Month. And since then, we've screened over about 6 million people. We're currently screening now. May, since COVID has expanded, it's now May, June, and July, to allow for the legacy, the adverse effects of COVID. But so we're screening, and we've got into over 100 countries around the world. We've screened over 6 million people, excluding this year. And it turns out that we've got about a third of those screenees are hypertensive. Amongst those screenees, about a half are being treated. This goes back decades to the rule of halves. And of those that are treated, about a half are getting their blood pressures down to less than 140 systolic, which is a sort of conservative target. If we go for 130 as the target, then we're down to about 1 in 7 or 1 in 8 of hypertensives are being controlled. And for something that kills more than anything else, it's just appalling. So that's what I think May Measurement Month has achieved. We've raised awareness. We set out to raise awareness of blood pressure in the population and at the individual level. So about a quarter of the people we've screened, 1.5 million so far, have untreated or inadequately treated hypertension. So at the individual level, I think we've achieved our goal. Have we got it out to the population? Well, going via social media, I'd like to think we have. I think we are reaching people, and Vilma and Pedro have stressed the importance of getting to the people. I think we have done that. We hope to do that, but we need to do more of it. So that's been the main sort of numbers around what May Measurement Month has done. And then in terms of the understanding, what's it added? Well, it's told us that we're not doing things very well at all. We're under-treating. Those who are treated, one drug is being used for the majority of patients. The guidelines tell us we need 2 or more drugs, and we should be starting with 2 or more drugs. So it's underlined that we're not doing it well. Too many people are receiving aspirin. They shouldn't be on aspirin unless they've got secondary prevention. Too few people are getting statins. It should be routinely added in for the vast majority of patients. And we've also had the chance to look at coexistent screening for atrial fibrillation. We've looked at things like blood pressure variability. We've created a framework for research for anybody here or anywhere else in the world. If they're interested in trying to look at a global question in hypertension, then we've got this kind of framework available for people to piggyback onto, and we hope they'll do that.
I could not have set this up. I mean, so again, you ended your comments with a research-based question. Alta, you've been involved with the WHO publication from this year on hypertension and research questions that are prominent. Neil mentioned one. Share a little bit more about that report and what are some of the other research questions we need to answer, and what are the best ways for us to go about that?
Yeah, thanks, Tom. And actually, to add on to what Neil said, I think in terms of May Measurement Month, one of the goals that we've set was also to make sure that systematic screening is implemented by government, right? So it's about the health system and to get the government to also see the value in that. And I think that links on with the WHO process that we've went through recently to set research priorities. What is the information that we still require to ensure better implementation of team-based care, better modeling what works best in the context of the country, simplified approaches, as well as especially single pill combination therapy. So what happened with this WHO strategy was we had interviews with many people across the world through webinars on different aspects, team-based care, single pill combinations, and also asked what other questions are out there that should be considered to make sure that we can advise strategies to governments to implement in health systems that are cost effective and scalable. So some of these key priority areas that were identified through all these webinars and that were published earlier this year was specifically on ensuring cost effectiveness of single pill combinations, models that are implementable and scalable, especially team-based care models, right? We have heard many stories of that. Some used community health workers, some used nurses to do this. Can it be regulated by governments? Because nurses cannot prescribe medications in many countries. Can nurses prescribe, and can they fill prescriptions? Can community health workers fill prescriptions? What are the safety and risks involved with that? So these were some of the key priority areas. And I think we need to think realistically if we want to go to governments and health systems to implement this. What will the questions be that asked? I think great success again in Latin America, but in many other countries, including in high-income countries, the system is quite resistant to change, right? And to make that change happen, we need to have all tools available, including especially cost effectiveness analysis.
Thanks. Neil, I want to just come back one other comment on opportunistic screening. I've been involved in some work in South Africa, and they're doing some screening in the queues for people picking up their pensions. And the Medical Research Council there has been quite interested in that project. What are the best ideas for opportunistic screening? Where is it happening? Is it happening in people's homes? Can we do? This morning we also heard a lot about the metaverse and the advances in technology. Where's the innovations in opportunistic screening?
Very important, Tom. Yeah. What we did with May Measurement Month was to say, set up your own pop-up clinics wherever you like. So we've done everything that you can think of, on trains, in airports, in shopping malls, anywhere that people were able to set up. We did it in the foyers of hospitals, so visitors to hospitals, everything you could think of. I think in the first instance, it doesn't matter if we're trying to just educate. If there's an education program driving people to do that, then they go and get it measured. Clearly, we will pick up a few spuriously high readings, but essentially where it happens doesn't matter so long as the sound, it's not too loud. And that's what we've encouraged. So we've had a whole range of sites, pharmacies, absolutely everything, people's homes. And you mentioned that. One of the things we did, I don't know if anybody recognized the Zoe app, which was introduced during COVID by a guy called Tim Spector. Through that, we screened about 50,000 people in UK in their homes. So we were able to look at UK screening outside the home versus in the home, and the things you might expect. But that's something, and I think it's something we would advise generally as we move towards trying to get the message out there that home blood pressure screening and running blood pressures by the patients, getting the community involved, so long as they're being educated, is a key direction to moving.
So sometimes, Vilma, to you, sometimes when we're doing the screening, we've learned that there's some challenges with equities and who gets screened or who gets treated, who gets managed. How do we deal with that? What are your concerns, and what are the ways for us to sort of counter the fact that maybe people, if we're doing it in shopping centers, it's people who are walking and talking and have the money to do that. So how do we make sure that we get everybody that's out there?
That's a difficult question, Tom. And in my view, the key is to go into the community, to map the community, and to identify what are the leaders in the community, what are informal leaders in the community, because they can open the door for us to get to the more marginalized people. And this takes time. To get this trust from the community, to work together, to make it really participative. We have different techniques and methodologies. We have focus groups and interviews and photo voice and a lot of tools that we can use. But to me, the most important thing is people. So we have to get this communication with people. And as Pedro usually says, it takes time. to get distressed and get involved in a meaningful way with the community.
Well, we're running out of time. Meaning, I think Neil would say that he was starting to, like when you said it takes time. I think his sense is like we're not doing things fast enough. But there are challenges, and you mentioned about understanding the community as an important way of doing that. Pedro, in different countries, can you explain to us what you've learned of what might work in Ecuador that is different than Argentina or somewhere else? What are those challenges you've had in trying to understand, well, at the national level, as you introduce these programs, what are the differences and what makes it work if you're trying to introduce a program like what you've done?
Well, I think that there are many commonality in terms of the why hypertension control is very poor worldwide, even in a high-income country. I think the first is a lack of political will and the sense of urgency. We have an emergency with the hypertension. It's the number one killer. And there are many priorities at the same time. For example, we're talking many times about how important is the NCD. And of course, NCD is so important, but I think that we need to call, cardiovascular should be a priority. And if we want to reduce the premature mortality due to non-communicable disease, the number one factor is cardiovascular, and the number one factor that you need to impact is the hypertension. And not all the time this is very clear. The second is a lack of understanding the role of hypertension as the main cause of the many NCD. This is another important topic. Another common issue, a common barrier, or common problem in many countries is the structural issue at the primary healthcare level. The facilities don't have the resources that they need. The facilities don't have a device, or don't have the lab, or don't have the medicine. They have, a burden of patients. This is structural. Every single intervention that we try to implement at primary healthcare level, have the same barrier for the implementation. We need to invest in primary healthcare level and in primary healthcare setting if we can improve the control of hypertension. This is an important structural issue. And there are at least three important topics that I can mention as a main barrier. One is the medicine, access, availability, and quality. Maybe when you ask in different surveys, particularly for the government, how is the availability of medicine in your country? They are very optimistic. Always the response is, we have a medicine. However, when we go into the survey, individual survey, one of the main barriers is the medicine, and particularly for vulnerable population, they don't use the type of medicine that we are recommending for hypertension. So this is one of the big issue. And the issue is not because we don't have this kind of medicine. No, because the prices is not accessible for many. And you know why? Because we don't have a pharmaceutical policy at the country level. So the main thing that we can do is how we can reduce the price of medicine. This is the number one priority. The second, Vilma mentioned, Alta mentioned about the team-based care with task shifting, with the participation we have a ton of evidence that this worldwide. However, in Latin America, I don't know in other parts of the world, I don't know in Europe, but in Latin America, the country, the physician, the power of the physician is too resistant, to share responsibly with the nurse, with the pharmacist. And we have a lot of information, we have a lot of evidence that this kind of thing works. This is the second thing. And the third is the lack of system for monitoring and information. No data, no program, no data, no progress. And this is that most of the country don't have health information system in place able to monitoring and evaluate the clinical, the monitor the patient and to evaluate the performance of the system. So I like to say, many times when you say, why the hypertension control is too low? So you ask this question for the physician, say, why? Because the patient don't follow the recommendation of the doctor. If you ask for the patient, why or other providers say, why the doctor? No, the responsibility are the doctor because they don't follow the guideline. No, the responsibility is the system in place. and we need to change the system in place. See, we want to improve the hypertension control.
Again, I couldn't have paid you for that last comment. Segue again. You mentioned last thing is, they're not following the guidelines. Neil, question to you. There's always this gap between what the guidelines say is ideal care and what actually happens on the ground. And the other panelists have mentioned many of those different challenges. Speak a little bit to the guidelines. Are the problem with the guidelines? Is the problem with the real world? Why is there a gap? And how can we either overcome it or change our guidelines?
Thanks, Tom. Yeah, there is always a gap. This isn't often, it's just always a gap. It's just a question of how massive that gap is between the guidelines and reality. And the causes really are multiple. I think part of it is getting a system in place. Most of the countries in the world, it's not a focus. There is no system. There is no routine screening. And they just haven't got an education necessary at the population level. The population need the education, as do the medical profession. And then we've got to work around that. And the guidelines that are produced go from huge documents, which are far too complicated. They're textbooks. They're brilliant for a hypertension expert. At the other extreme, Pedro's, the heart, those one pages. You had the same in South Africa, didn't you? A one pager. They're superb. They're excellent. You may disagree here and there, the physician about which drugs, etc. But any system that's simple like that is much more likely to work. So that's, and in between the ISH guidelines, sort of 20-pager, that's been taken up quite well. But I think there are real problems with those guidelines. And it's down to the education and the resource that's put into it. It's the impact and getting the population involved. You mentioned earlier about the sort of getting to the populations, the diverse, underserved populations. That's the real difficulty. And one of the things that MMM has done, some of the people have gone out in vehicles to places where 90% of adults have never had their blood pressure measured. That's just terrifying that that's the case. And so we're trying to get to those people as well, and we need to do that.
Thank you. I think, Pedro, you mentioned something about the power of the physicians, or how they control either writing the guidelines or what's the management. Don't assume any responsibility for the lack of control. There was a discussion this morning by Joe Hill, who said, he talked about HIV and how it's gone from a disease that has killed everybody immediately to one that is actually well controlled. We think that can be for hypertension, but the initial AIDS drug regimens were quite complex. But in South Africa, at some point in time, those were turned over to nurses delivering those prescriptions, community health workers delivering those medications. And for 20 years or more prior to that, we had good antihypertensive medicines. But when we were working in South Africa, nurses initially were not given prescribing authority. So I want to each of you to make some kind of comments on what is ideal, maybe either in your own country or elsewhere, when who should be delivering this care. What are different sort of models that have worked between who can prescribe, who can deliver, thinking about safety, but also increasing access? Maybe Vilma, you start with?
Thank you, Tom. I think that we have been talking about clear protocols and simple protocols. And if we have a standardized protocol, so we can involve non-physician providers to follow those protocols, to have supervision from other colleagues. But to me, nurses and community health workers and other members of the healthcare team can, following a standardized protocol, be able to accelerate the process of getting medication to people. That's key.
Pedro, so what's the experience across the different countries you're working with in terms of prescribing?
Yeah, I think that's, the cultural issue is we need to be respect, how the country think, what is the natural scenario to improve the control of hypertension in different countries. But in general, the recommendation of PAHO and how in the American is the prescription is the responsibility of the doctor. You prescribe the medicine, however, the nurse, the pharmacist can follow the treatment, based on the plan, based on the standardized treatment protocol. It's the same thing. I like this kind of example. You have a very severe patient intensive care unit. You don't have a, doctor 24 hours. The doctor only, prescribes some kind of recommendation, and even for very serious condition, the nurse is able to dispense this kind of medicine. So why not in hypertension? We have a very safe kind pill. We have a very standardized treatment protocol. So, however, the good thing is that, the country is moving in this direction. Many Caribbean countries now are working to expand the scope of work in nursing. Of course, they need to change the fiscal policy, the regulatory policy at the country level. Chile, for the first time, they approved the use of the pharmacists to follow the medicine at the community based on the prescription original made for the doctor. So I think we are in the right direction. However, we need to talk in all forums talking about this important addition to the program.
I'll take you share from your experiences, whichever country you want to talk about.
Let's start with South Africa. You referred to the HIV experience there. And what is interesting is that they actually have a quadruple single pill combination that's prescribed by nurses, and that's even now available in vending machines, right? So without there's several different models that's useful, and what is important there is HIV was urgent. Why is high blood pressure never urgent? That's always the problem we have with NCD. So we're taking ages to learn from the HIV experience, but we have actually that same urgency. So I'm not saying we should necessarily use vending machines, but we can go for single pill combinations. Why is there such resistance against things that can work? You referred to briefly, Pedro, to pharmacists. I mean, there's been really good evidence for pharmacists in mostly perhaps in high-income countries, but they can prescribe and let the whole care process has been very effective, much more effective than with GP prescribing in terms of getting blood pressure control. And I think we shouldn't be hesitant. The problem, as he has said, though, also is that GPs are very resistant to handing that power over. And I don't know how we can change that whole trust relationship to say this is all to the benefit of the patient and they won't lose anything in terms of managing patients.
You mentioned, in vending machines and things like that. And I know that the UK went through an experience with behind-the-counter statins. And tell us about what that experience is of patients asking for something, or pharmacists managing a program for hypertension or for anything cardiovascular disease, and what do you think the benefits and the pitfalls of that?
I think easy access is one of the key things to the drugs wherever we are in the world. Interestingly, the general practitioners in the UK are trying to, or some of them are trying to hive hypertension management off to pharmacy, which is okay, but there's a financial implication for that. The pharmacists want to do it because there's payment for it, and in the investigations they charge for ABPMs, etc. So it's a sort of first world type of feel to it. I think the African experience of HIV being prescribed by nurses, but not for hypertension, just is a clear clarion call. They should be able to prescribe. Hypertension management is essentially easy. If we get single pill combinations, 2, 3, 4 drugs in a single pill, it's easy. The one glitch to that is the measurement. The measurement should be done properly. If we do it properly, then I think community health workers should be able to do this in most parts of the world. And we should be training people to do that, perhaps with remote support from hypertension doctors, but essentially it's done very simply with simple regimens, single pill combinations. That's the answer. And the other thing that none of us have mentioned is non-pharmacological intervention. It works. And despite the fabulous trial, Bruce Neal in China with the low salt product, we had 10 years ago, more than that, we showed that beetroot juice works, 8 millimeters systolic from taking beetroot juice. Now, beetroot juice is very, very cheap to produce. We should be promoting nitrate-rich products, low-salt products, and switching rather than stopping salt intake, because we won't do that, but switching from sodium chloride to potassium-enriched salts could have a huge impact. And all the other stuff nobody wants to hear about, like exercise and weight loss and booze, we've got to get that into education. We have to do that. Because if we do it, we'll make the drug treatment so much easier and will preempt the need for drugs to a significant extent.
Paige has a comment on that, but I'm turning to you. You guys are coming up next. I expect questions. after this answer, and I maybe one other question, but we want audience participation. So if you don't ask me them a question, I'm going to ask you a question. So that's your challenge. Go ahead, Pedro.
I think the other important addition when we're talking about this kind of thing is that we need to, the university should be part of this effort. Many times the university is very behind, in relation with this topic. The education continue to be a silos, for nurse, for pharmacists, for medical, that even in the same school of medicine or the school of medical science, so they never have a place, to share the role, how the people work in the community in the future. Never the university, talking about this. So after their graduation, how you can change the mind of the people, because this is a physician, this is a nurse, this is a pharmacy, and they don't talk, So this is important. So why not in some way? I think that we need to, the international organization and the community, scientific community, need to invite the university to change the way that they are doing the same program that 50 years ago they continue doing the same thing with the same result.
4 experts, you have opportunities to ask a question. Who's going to be first? Go ahead.
So community engagement is important. There are also concerns of the community regarding the drugs, like because it has to be taken lifelong. It is probably the physician's responsibility to convey it, but all the same, they have concerns, and that is the reason why they stop also. Because it has to be taken for a long duration, they think it might harm their kidney. It causes kidney injury. So that those kind of perceptions, do you have such perceptions in your country, and how do you manage them?
Can I chip in?
Just to make sure that I want everybody here. So the question, to paraphrase, is that when you make the diagnosis and you commit somebody, you're committing them lifelong to treatment, potentially, unless they lose weight and eat better. They may be committed to lifelong. So tell us about your responses to this dreaded lifelong commitment to these therapies.
It's a critical question and really important, because the patients do ask that. What are the side effects, doctor? And my first reply is, you will live longer. You will have less likely to have a stroke, and you are less likely to have a heart attack. And nothing I can give you with this pill is as bad as a stroke. So if we start with that premise, and the idea about, will I have to take this all my life? Your life will be longer if you take this, if we start with that. But I agree with you, you can be flippant about it, but we also have to make them understand that what we're giving, what we do give, what we should be giving, have been shown to prolong life. And yes, there are side effects. I think we have to admit that, say what they are, and say, but if you get them, we can give you something else. Live with it, etc. So it's communicating, it's working with the patient, that it's their decision. They want to take it because they don't want a stroke and because they want to live longer.
If I can add to that, I also agree how important this aspect is. And I do think we need to start working closer with communities and empower them. I think Wilma referred to that yesterday also in a presentation. It is, if we don't, especially in those communities where 90% have never even had a blood pressure check performed, how would they understand what to do with those numbers, and even if they have to have treatment? So that whole communication and educational process, but that engagement and inclusion, I think, is essential. And in many instances, there's more and more movement towards patient guidelines to understand what is high blood pressure, how to interpret the numbers, how to do home blood pressure monitoring if that is available, and when you take medication, why it is important to take it for a long time, because GP when it's at a GP practice, those time commitment of 5 or 10 or 15 minutes is usually not enough to give all this information thoroughly. So that is where team-based care is again important, to engage better, to follow up and make sure that these messages get across and there's understanding and acceptance and empowerment of the patient.
Well, in here in America, we say that the standardized treatment protocol, the clinical power, is a patient resource too. It's a patient tool. So can you imagine, you go to the office, a medical office, and they say, and they, see the poster, with the standardized clinical power. The patient asks, why my doctor don't follow the rule? And this is the recommendation, and this is the position that I need to take my blood pressure. This is the medication that I need. So we need to empower the patient with the real information, very well informed. No, with the fake news, using all the kind of thing. Use the standardized treatment protocol as a managerial tool, as a clinical tool, and a patient tool to be very well informed with the patient, in the decision of the doctor.
Vilma, we've talked, many times we've said the patients are passive, and I think what you're suggesting is we should encourage them to be active. Any thoughts about your work in the community or how we get patients to sort of take their own care into their own hands and work within their community?
I think that listening to all this discussion and our colleagues, Tom, you and I work in implementation science together, and we always say that there is this gap between what we know and what we do in practice. And listening to this discussion, I think that we have many gaps, not just one gap. And we have to create many bridges, not just one bridge, and some of them are connected with the community. The community usually is open. To me, one of the main challenges is that doctors, we are not good communicators. As simple as that.
Any other questions? Go ahead.
I'll ask. Hi everyone, and I guess we all agree, and we're a lot of nodding because I think all of us we think alike, and patient empowerment, community engagement, simplification of treatment, innovation in terms of technology. But we've been saying this for a long time, and maybe it's me being impatient. I think there is little progress, and it's hypertension, we know how to treat it for decades. So I would ask you if you can tell one thing that we are not doing now that you think that we should think. It could be policy, it could be healthcare service delivery, or it could be clinical, but something that we are not doing now, and you're saying we should be doing, and it's not part of the current discussion.
So I want each person to answer that, and any other final concluding remarks you have. Excellent question, Pablo. Thank you. So what's one thing we're not doing, and then if you want to add anything else, maybe that is the answer. Your last sort of thoughts on this topic.
Am I allowed two things? First of all, I think we've said it before, but we've talked about single pill combinations. We are not using them, and we're not using them because the trial evidence isn't good enough there to persuade the powers that be. We've got to improve on that, get more of them, and get them out there. That's the one thing. The other thing is that I think I'm massively impressed by the community health worker program in Brazil. That has, to my mind, been a revolution. And I think that's an example for many parts of the world, not the first world yet, although they're doing it in London. They've introduced it in London. So those people working alongside the community and working with nurses delivering, or certainly not necessary to have doctors delivering the drugs, would make a hell of a difference, a huge difference around the world. They're my two things.
For me, it is creating that urgency on a policy level as well. So just briefly from Australian experience, we've seen that the blood pressure control rates in a first world country is really 32% in Australia. So we published a call to action. We have flyers now with the Minister of Health, and he's opened us opportunity to create a hypertension task force for Australia now for the first time. So I'm knocking often on Pedro's door for information. He's on our international advisory and on others. And that is to create that urgency, open that pathway and discussion, and then start implementing all things like single pill combination therapy, etc. Those policy changes are required because in Australia, they cannot prescribe single pill combinations as initial treatment because the drug labels indicate it's not for initial treatment. So they have to change all generic drug labels, and the government needs to do that because pharmaceutical companies won't go for those changes. So it's all these barriers that's systematic where we need policy involvement.
Nodding, but I'm nodding that there's a problem. Pedro.
Well, it's a very provocative question, Paulo. The first thing I agree with Neil, and very agree with Alta. I see the one important addition is the have a health information system in place. patient portal and system for monitoring and evaluation. We need to share this information with the community. We need to share this information with the politician. We need to share this information with the people. This is my clinic, and this is your clinic. My clinic have 40% control hypertension. Your clinic have 30% of control hypertension, and your clinic have 10% of control hypertension. Why is so different? And this is the way that we have to, in some way, to declassify. What is the main issue at the health system. So that for me, in addition that you mentioned before, is have a system for monitoring and evaluation based on the strong health information system is important addition to move forward.
And we have, adding to all these important aspects, we have to learn how to communicate with policymakers to find the right window opportunity to implement these great ideas. And I think that we have to learn how to communicate better with policymakers and with the civil society. We communicate well in the academic field, and working with the community as well. But to me, our main weaknesses are related to policymakers and the civil society.
Thank you, everybody. That brings towards the end of this Art Cafe. Please come back here tomorrow at the same time.
Yes.
At the top there.
ACBD, Asia Pacific.
Asia Pacific.
Asia Pacific.
ACBD. So please come back. But first of all, can we thank our esteemed panel here?
Well,
Thank you. Thank you.